This is my first ASCO conference, and I'm here because I want to delve deeper into clinical research on cancer. And I've been studying cancer for the past 1 year, and previously I was studying psychology and neuroscience, and so I'm excited to be able to apply that interdisciplinary experience to the cancer domain.
As an interesting intersection of the physical biology with the more whole patient holistic attitude of things.
Yes, yeah, definitely. So the work that I'm presenting here was an exercise study, and that's my primary interest too. So I'm interested in side effects from chemotherapy, especially chemotherapy-induced peripheral neuropathy, or CIPN, and using exercise to treat that toxicity. And that's some of the data that I presented here today. And in the future work, I'm going to be studying how exercise affects the brain and as a mediating factor for that toxicity and others.
Okay. Well, exercise has recently been linked to being able to prevent the chances of developing cancer, being able to improve treatment during cancer and improve recovery after. What is your research focused on in terms of the platinum-associated toxicities?
Yep. So I studied chemotherapy-induced peripheral neuropathy, or CIPN, and CIPN is a big problem right now because it's highly prevalent, associated with platinums, taxanes, zinc alkaloids, bortezomib, and thalidomide chemotherapy regimens, and there's no established treatments for this toxicity. There have been over 50 randomized clinical trials testing drugs, but still no established treatments. And more recently, some studies have been showing the promise of exercise to treat CIPN. And ours is the first study. It's a very large randomized clinical trial. It was a secondary analysis, though, in 314 cancer patients. And we studied the effect of exercise on CIPN. And we showed that exercise was beneficial for CIPN when performed during chemotherapy compared to chemotherapy alone. And we showed that the effect is particularly strong for older patients.
Okay. Can you just explain some of the patient selection and how the arms were divided there?
So there was an original randomized clinical trial that we derived my sample from, and that trial was led by PI Karen Mustian, also at University of Rochester Medical Center. And that trial had about 619 patients. They had to be chemo-naive, non-metastatic cancer, at least 70 KPS, over 21 years old, and they had to be sedentary. Then I restricted that sample further down to 314 patients by additionally requiring that they were on one of these CIPN-inducing chemotherapy regimens that I mentioned, which was previously established in the literature. So it had to be platinum, taxane, zinc alkaloid, bortezomib, or thalidomide, one of those 5. I'd like to mention too, this was a nationwide trial through the NCI Community Oncology Research Program, or NCORE, and so it was good that we had a diverse sample in that regard across the country. And in the future, actually what we're thinking of doing is designing a randomized clinical trial with this toxicity as the primary outcome, CIPN as the primary outcome, and we will be focusing on people who have these symptoms. I'm really excited that I was awarded a Best of ASCO for this abstract and was able to present an oral presentation. And I think the reason is because people realize that this is a highly prevalent and severe toxicity. We have no established treatments, and we're just at the cusp of understanding what behavioral interventions like exercise can do for cancer and cancer treatment toxicities. And I hope that in the future we'll have a lot more studies, a lot more positive results using exercise, and that we'll be able to understand how exercise works mechanistically in affecting these toxicities through the brain and through inflammation and other factors that we're going to be thinking about, including psychosocial factors.